Good evening. I am Guillaume Fargeot, and I am working as a neurologist and neurophysiologist in Paris. On behalf of Canon, I am very pleased to welcome you to this webinar dedicated to nerve and muscle ultrasound. Why talk about neuromuscular ultrasound? In recent years, neuromuscular ultrasound has become an essential tool in the diagnosis of many neuropathies, not only entrapment or traumatic neuropathies. And clearly, it is advantageous for patients because it is a non-invasive and painless diagnostic test. Tonight, we will shed light on how ultrasound can be a helpful tool for the diagnosis of inflammatory neuropathies, such as CIDP, vasculitis, or neuralgic amyotrophy, and also contribution in motor neuron disease, such as ALS. These diseases are not so rare, and the therapeutic implications are very important for patients. Ultrasound has clearly become a first-line investigation for inflammatory neuropathies. It can clearly reduce the diagnostic delay and help to identify patients with treatable inflammatory neuropathies and thus allow early treatment. For ALS, we will see how ultrasound can support the diagnosis in addition to electromyogram and how it can become maybe a biomarker. I am delighted to introduce two great speakers tonight who are actively involved in the field of neuromuscular ultrasound, not only with patients, but also in terms of teaching, training, and research. First, we will be listening to Dr. Alexandra Borchert, who works as a neurologist at the University Hospital in Düsseldorf and heads an outpatient neurological clinic in Aachen, Germany. She is specialized in neuromuscular ultrasound, of course, diseases of peripheral nerves and muscles, and clinical neurophysiology. She has also developed a focus on surgery of peripheral nerves and works together with surgeons specialized in reconstructive microsurgery. The second speaker will be Dr. Nens van Alfen. She is a neurologist and a professor of clinical neurophysiology at the Radboud University Medical Center in Nijmegen, the Netherlands. She is also the medical director of the Clinical Neurophysiology Laboratory and coordinator of the Clinical Neurophysiology Residency Training Program. Her areas of expertise are neuromuscular ultrasound, of course, peripheral nerve pathology, and electrodiagnosis of neuromuscular disorders. I had personally the chance to spend 1 week in her clinic, and I can assure you that she has an incredible expertise and teaching abilities. Well, we will now listen to Dr. Alexandra Borchert.
Good evening, everybody, and thank you, Guillaume, for this very good introduction, and thank you, Canon, for the invitation. We divided this webinar about neuromuscular ultrasound into two parts, and I will start with the first part about ultrasound in the diagnosis of inflammatory neuropathies. I would like to start with a case to give you an example how to use ultrasound in neuropathies. A 53-year-old woman visited us with a slowly progressive sensory and motor loss of ulnar nerve since 2 months. And we performed a nerve conduction study and found a normal sensory nerve conduction study of the ulnar nerve. And in motor nerve conduction study, we found an axonal loss in ulnar nerve and an incomplete block at the forearm. And even though this case is about 12 years old, we did next nerve ultrasound. And in nerve ultrasound, we detected a focal enlargement of the ulnar nerve at the forearm with a cross-sectional area of 18 square millimeters and a hypoechoic aspect over a distance of about 4 centimeters and a normal appearance of the ulnar nerve proximal and distal to this lesion. And so in this case, nerve ultrasound added value to the nerve conduction study for the diagnosis, and we could focus very quickly on this level of the ulnar nerve and ask the radiologist to do an MRI with a high resolution of this region of interest. And we found a gadolinium enhanced ulnar nerve over the same distance as detected with ultrasound. And because this patient has a mother with a PNS tumor, we performed surgery and biopsy. And there we also found this enlarged focal ulnar nerve with a red color as common in inflammation. And the histopathologic workup also showed no tumor, but inflammation. Laboratory results were normal, and as a conclusion, we diagnosed inflammatory neuropathy, a Lewis-Sumner syndrome, also known as MADSAM, and we treated this patient first with steroids. There was no response, and afterwards with IVIG, and the patient had a good response and improved over time very well. So in Lewis-Sumner syndrome, in the demyelinating inflammatory neuropathy, we found enlarged nerve. And at that time, several groups started to scan systematically patients with neuropathies to detect enlargement. And they started to detect proximal parts like the brachial plexus and the cervical roots, also the vagus nerve in GVS patients, and the median nerve, the ulnar nerve, and also the nerves of the leg and its branches. And we learned that in inflammatory neuropathies, we find enlarged nerves like in CIDP, in MMN, in multifocal motor neuropathies, or demyelinating inflammatory neuropathies. And we could detect if they are regional or multifocal or generalized. And we found out that in proximal parts, we very often can detect enlarged nerve in an early stage of the disease. And that it is also typical that we do not find enlarged nerves at the level of entrapment sites, but next to these, at the forearm, at the upper arm. And this I would like to show you in the next case, a CIDP patient with typical findings in ultrasound. And the first nerve is the median nerve at the carpal tunnel and the forearm. And as you can see here, we have a normal cross-sectional area at the carpal tunnel with 8 square millimeters and an enlarged cross-sectional area at the distal forearm with 22 square millimeters, more than 50% enlargement compared to the normal parts. And in ulnar nerve, we scanned the upper arm and found at the one side a normal ulnar nerve with a cross-sectional area of 7 square millimeters and an enlarged ulnar nerve on the other side with a cross-sectional area of 64 square millimeter. And in sciatic nerve at the fossa poplitea, we could find a normal nerve on the one side and an enlarged nerve on the other side. So these are typical findings in CIDP patients. And we find enlarged nerves, but we also find caliber changes in fascicles. So we have to keep a good eye on the inner structure of the nerve. If you have a nerve in transverse scan, you have hypoechoic areas, the bundles of fascicles, and between these bundles, hyperechoic, interfascicular epineurium. And in a normal nerve, these bundles of fascicles and fascicles are more or less homogeneous in size during their course. But in inflammatory neuropathies like CIDP, we find at different levels, different sizes of fascicles and fascicle bundles during the course of the nerve. And this I would like to show you in this median nerve at the upper arm. Here's the median nerve, and please focus on the inside of the nerve. where you can see the changes in caliber of vesicle bundles and changing during the course of the nerve. And in the end, nearly all the bundles are enlarged and the whole cross-sectional area of this nerve is enlarged. This is also very typical. So in inflammatory neuropathies, we recommend to scan the whole nerve, not only put a spot on one level and see how the cross-sectional area is there, but scan the whole nerve and detect the enlarged segments, including the proximal segments, and scan slowly and keep an eye on the inner structure of the nerve. Note also clinically not affected nerves and muscles and compare left and right. And also use Doppler and low flow imaging for suspected vasculitis. Like in this case of an ANCA-positive vasculitic neuropathy, where we can see a sural nerve and an increased vascularization around the sural nerve, but also within the sural nerve. Ultrasound is also a very valuable tool in the diagnostic of neuralgic amyotrophy. There, we have the opportunity with ultrasound to detect nerve swelling and constriction or torsion. We find constriction or torsion of nerve or even a single vesicle and one level or more levels, like 2, 3, or even more levels. And in transverse scan, we usually find the focal swelling next to a reduced cross-sectional area and then the focal swelling again. And in longitudinal scan, there's the typical hourglass-like formation. And then we have an example of the radial nerve at the upper arm, where we can find changes in caliber and swelling next to reduced cross-sectional area, like a development of constriction and also a complete torsion, which you can see in the intraoperative view. And in MR neurography, you find at the level of the torsion usually the typical bullseye sign. And in longitudinal view, also the hourglass-like formation. And this is very similar to the intraoperative finding. And these nerves are intraoperatively often of a bluish color because of ischemia, because of the torsion. And we all know that in neuralgic amyotrophy, there's a group of patients with a high function, high grade motor loss and no improvement during 3 or 6 months. And if we can detect in these patients with ultrasound or MRI constriction with torsion, there is, at that time of our knowledge, an international agreement to that these patients should receive surgery to remove the torsion and to improve their prognosis. So as a conclusion, we have the opportunity with ultrasound in neuralgic amyotrophy to detect focal swelling and vesicular enlargement. We know that the most affected nerves are the brachial plexus, the suprascapular nerve, the long thoracic nerve, the musculocutaneous nerve and radial nerve, and that very often the distal upper arm is the site of the affected nerve. And we can detect these changes in early stage until 1 year. And we can detect the group of patients who should receive surgery to improve their prognosis. And so ultrasound improves the accuracy of detecting treatable nerve lesions and can shorten the time to diagnosis and also improve early treatment and prognosis. And this is also an improvement of cost effectiveness. And so I say thank you very much for your attention, and Nens van Alfen will continue.
Good evening, everybody. I'm Nens van Alfen, and as you can see, I'm almost in the garden. I hope you have a nice evening as well. For those of you who are unfamiliar with muscle ultrasound, this is just a very short demo of how you can standardize these images by putting the probe on a pre-selected site, the maximum bulk of the muscle, that is denoted by that little pen line there. And then you take the 3 images in a really nice 90-degree angle view to give you a bright image of the muscle overall, and you annotate. And then you take these offline. And the nice thing about muscle ultrasound is if you keep your probe and presets completely standardized and you don't touch anything, you can make really good comparisons from one patient to the next, but also for one patient from the first measurement to the next. So we use ultrasound a lot in our lab to diagnose people with neuromuscular disorders. And it's like, I would say, any neurophysiology test, this technique is quite sensitive to detect pathology, although it's then not specific. So, you know, people have some form of neuromuscular disease, but you still have to do other, you know, thinking and stuff to know which one. But we also use it to monitor people during, well, treatment trials or for progression of disease. Now, how might this help or inform your treatment of patients with suspected motor neuron disease, or more particularly ALS? Well, if you look at the criteria out there that obviously were designed for incorporating electrodiagnosis, then I think laboratory support is for lower motor neuron loss is what ultrasound can add, and basically can add just as well as electrodiagnosis can. So you are looking for support for finding loss of motor neurons in the sense that a muscle may be denervated, showing you fasciculations and fibrillations, spontaneous activity, if you will. And then if there's sufficient denervation, the muscle will also atrophy. And then the ultrasound image will become increasingly white as the muscle texture deteriorates. But that's not all. Obviously, there are other things that are very important in ALS. So we also use ultrasound to scan for bulbar dysfunction, dysphagia, and also for the diaphragm, intercostal and abdominal muscles to look at the respiratory status of patients, where we try to help predict whether they need, well, positive pressure ventilation, etc. Now, before we dive into ALS further, maybe we should have a quick tour of what muscle ultrasound will show you in different stages and severities of denervation. So here are a few examples. This is a 70-year-old woman that we scanned because of a suspected C6 radiculopathy. And she had that, the onset was like a couple months ago. And when we compared this image to the EMG, this was again, a completely re-innervated muscle already. So not too bad, the radiculopathy, mild denervation, but then after a couple of months, collateral re-innervation, and again, a normally innervated muscle without any spontaneous activity. And this biceps muscle that you see here, this is the outline of it. Here is obviously the humerus, and this is brachialis. Here is the subcutaneous layer, that's the skin. This is a normal looking muscle for a woman of this age. So when you have complete re-innervation in a muscle, the ultrasound usually won't show you much. And that is, I think, something you need to be aware of. It's not a good screening tool for mild denervation with re-innervation of the muscle. But if you do not have complete re-innervation, like this young girl who suffered a forearm fracture and then medial and ulnar nerve injury, then it will show abnormalities. So I think this girl was about 7 years old. This is her non-affected right side. This is her affected left arm. This is the medial side of the forearm. And you see these muscles overall are much wider than the normal looking muscles on the other side. And the same goes for this ulnar region. This is the ulna. Here is the deep finger flexor compartment. Let me make that brighter for you. This is the deep finger flexor compartment. This oval shaped muscle is flexor carpi ulnaris. And if you compare it to the contralateral side, it's much smaller, and it's also white. So like this, for this young girl, in this case, ultrasound can even pre-screen your needle EMG, because looking at the distribution pattern of these abnormalities, you already know that this girl has denervation in the ulnar and median nerve distribution. And that might save her some uncomfortable electric shocks or needle sticks. If we take it one step further, this is what a progressive denervation with reinnervation might look like. And these are images all from patients with spinal muscular atrophy. So a slowly progressive motor neuron disease where there is time over the years to reinnervate until all motor axons and motor neurons are lost. And during that continuous denervation, reinnervation process, you get something that's called a moth-eaten appearance, or some people call it a Swiss cheese, where you have like this biceps muscle, and this is another biceps muscle. You have these holes in the muscle, black areas, maybe it's most conspicuous in this one, black roundish areas surrounded by white. Well, the white is actually fibrotic, completely denervated muscle tissue, so that's already gone. And the black holes are areas of remaining viable motor unit tissue that are still innervated. And usually if you would stick an EMG needle in this, it's a very large amplitude, long duration motor unit. So this is chronic denervation and reinnervation. And then obviously, if there is no chance of reinnervation, like complete axonal loss after a nerve injury or root injury in this case, you see this gastroc muscle, the white shadow here, is completely fibrotic. It's not even recognizable as muscle tissue, to be honest. I mean, you know, this is subcutis, this is skin, there's a small subcutaneous vein here, but this is all fibrosis. So that is sort of the sequence you might expect with increasing severity of the axon loss. Now you could do more with ultrasound, because this is a short video which is zoomed in of the quadriceps muscle. This is a skin, subcutaneous layer, fascial lining of the quadriceps. And here you see the top half. And if I turn on the video, you see a slight trembling. But if you look closely, it's not the whole image that's trembling, it's just the muscle part. So this is what a lot of fibrillations look like when you have an ultrasound image of them or a video, and you have turned the smoothing software for this image off. I mean, if you have these nice image optimizing presets or functions on your machine and you turn them on, it will probably think this is noise and make it disappear. So you need to be able to turn that off. But this is fibrillations, actual small muscle fiber trembling movements. Now, obviously, this was a little bit unexpected maybe, because it's a very tiny muscle fiber that's actually moving. So over the years, we found out that you need at least 5 fibrillations per second to be present in the EMG for you to be able to see them on the ultrasound. And you need a high enough frame rate, so enough video frames per second to detect the movement. For ourselves, the first thing we did was denervate a lot of muscles. This is the extensor digitorum brevis on the foot. And then we stuck a needle in. This was a different project looking at end plate zones. But we used this muscle to simultaneously record the ultrasound signal and then hear the EMG. I hope you can hear this, but if not, you can see the signal here, which is the fibs. And this is the needle in the ultrasound image that's recording from this denervated muscle. So this proved to us that this is actually fibrillations. Now, if we go a bit bigger, fasciculations, which are motor units that are spontaneously firing, so to speak, and they are completely random, these are very easy to see with muscle ultrasound. So if I turn this on, this is the medial gastrocnemius muscle with the soleus. You see all these unexpected random twitches in the muscle, just like you would see them from the outside, basically. Only now you have 3 muscle layers to look at and a pickup area of 4 by 4 square centimeters, which is larger than your EMG needle can see or hear. So ultrasound is excellent for looking at fasciculations. This is another example. This is again the arm with the biceps here, humerus, and then brachial artery on this side. If I turn the video on, you will see the unexpected random muscle jerks. Those are fasciculations. I think if you've seen it once, you will recognize it the next time. So how does this all help patients with suspected ALS? Well, even if you're not looking at muscle texture or echogenicity, fasciculation screening can really help. So, like I explained just now, the pickup area of a concentric needle is a hemisphere with a pure area of only 0.07 square millimeters. And obviously, you can hear activity from a little bit further, but it won't spread more than like 0.5 centimeter to a centimeter. Well, the ultrasound video has a very large pickup area because of the size of the probe and the screen. So there have been multiple studies out there, more than, I don't know, 25, 30, I think, at this point, that looked at the detection rate of fasciculations with ultrasound versus needle EMG. And you always tend to detect 20 to 33% more fasciculations using ultrasound. So you can improve your detection rate. And there's even a group that looked at fasciculations as a prediction score for whether this patient, I must admit, within the right clinical context, had ALS or not. So if you scan 9 muscles and you find fasciculations in 2 or more of them, in that clinical context, that is a very sensitive marker and also quite specific for the patient having or turning out to have ALS during follow-up. Now, what is also known, but this also goes for the EMG, obviously, is that fasciculations have a temporal detection window. So if the muscle is still relatively intact, there will be lots of fasciculations, and you can find most of them in biceps brachii. But once the muscle progressively denervates and becomes atrophic, then obviously there's not enough muscle tissue left to fasciculate, and then they will disappear over time. And the optimal scan time with ultrasound, this has also been looked at in multiple studies, is about 30 seconds. If you really want to be sensitive, you might add another 30 for a full minute. But I think you will find most with just 0.5 minute of screening time. And what about echogenicity? So how bright the image is? Well, there is a very common ultrasound pattern at the time of diagnosis. So the time when a patient presents to your clinic with the first time with the question, could this be ALS? And that's usually that you find a lot of fasciculations, some muscles with abnormal echogenicities because they have already been sufficiently denervated, and only a few muscles with real severe atrophy. Once the disease progresses, this will obviously change. We have looked into a sizable cohort, I think about 60 patients, and then we compared quantitative muscle ultrasound, so the echogenicity and fasciculation scores, with for patients who were suspected of having ALS, but they were all relevant mimics plus ALS. So about half had things like radiculopathies or IBM, and the other half turned out to have a motor neuron disease. And then the sensitivity prospectively determined was 96% just using ultrasound alone, not even EMG in the neighborhood. Specificity was around 84%. And if you look at EMG, these numbers are similar. So you might use either technique as a standalone, but I think the best thing for your patient would be to combine them, because that's another group from Japan who looked at combining ultrasound with EMG. And they found that at the time they present to your office, if you do this, you can give 25% of your patients a more certain diagnosis at the time of their first consultation. And I think that's really relevant for the patient. They don't want to know if they have possible ALS. They want to know if this is a disease that will kill them early. And this helps. So just a quick case example here. This was a 60-year-old female that was presented to us because she was suspected of having an immune-mediated myopathy. And her symptoms had started a year earlier: proximal limb weakness, head drop, and she progressed to wheelchair dependence. There was a generalized atrophy, MRC grade 3 to 4 weakness all over, a slight dysarthria, fasciculations, but not a lot in the deltoid, no sensory abnormalities, and she had extensor plantar responses. So clinically, this already appeared to be a combination of a peripheral and central nervous system motor disorder. And then I think the differential diagnosis is not that big. She had normal or not non-explaining MR scans of her neck and her lumbar spine. Let me show you something you're probably very familiar with. This is her needle EMG exam. So we do both if there's a strong suspicion. And then you see that every muscle we looked at, there was denervation and fasciculations. And the only muscle we couldn't identify that in was the paraspinals because she couldn't relax them. But there were enlarged polyphasic motor units here. Now, this is just a few representative examples of her ultrasound. And I've put a normal person on the left of the screen and then the patient we just discussed on the right. Same age, same build. So here you see again, skin, subcutaneous layer. That's vastus lateralis. This is vastus intermedius, and that's the femur. And you can see that compared to the normal person, this is a smaller muscle and it's white. So that's already abnormal. This is her medial gastroc. Again, on the left, a normal person, same age, same build. And you can see it's very white, even so white that it becomes hard to see through it to the underlying layer of the soleus. And you can see the fasciculation screening here. Sorry, I'll turn the laser off and the video on. And so this is biceps brachii, which is actually the muscle that tends to show the most fasciculations. And you don't need to look for 30 seconds to see that there's a lot of fasciculations in here. You might note here in the lower right end of that video screen that this has a frame rate of 72 Hertz, which is excellent because you need to be able to pick up these quirky, quick movements. So make sure you look at that frame rate and keep it above, say, 20 Hertz. Now, I think you've seen this one already, but this was her gastroc with the fascics in it. So you saw a movement here and there. And I think there's also the deeper layers that are affected if you look long enough. And the thing about fasciculations is they should be unpredictable, totally unpredictable, right? So if it's a small area of muscle that's moving, but it's always the same, it's probably a large motor unit that's firing, that's not completely relaxed. So this is a suggestion for a screening protocol when you want to use ultrasound for ALS. We want to scan 4 regions, just like we do in EMG, and then at least 2 to 3 muscles per region. And then it's a confirmatory study that is fitting the diagnosis of ALS if you have at least 2 muscles with an abnormal echogenicity in them, so like the biceps and the medial gastroc that we've just looked at. And you want to find fasciculations in at least 4 muscles, and ideally also in these different regions that are outlined below. So 1 or more in the bulbar region, 2 or more in the cervical, 1 or more thoracic, and then lumbar. And in all, this is a very suggestive result. We tend to represent our muscle ultrasound studies with these little graphs for the clinicians, where now it's the darker the muscle, the more abnormal the echogenicity. And this is the protocol actually that we scan for ALS, looking at all these different muscle groups. But you might be able to do more. So this is a group from Kuala Lumpur in Malaysia who looked at the possibility of developing a prediction model for patients who have ALS and try and find out whether they will progress fast or slow. And what they found, and I think that's very relevant, is that there is not one single parameter that's able to predict everything in those patients. So if you look at neurophysiology techniques, there is never a single study that will be able to tell everything about every patient. I think it's common knowledge, but sometimes research tries to present itself as, the new thing to do. But what they did was actually pretty clever. So they combined 3 measures. They combined the ALS functional rating scale score, and then the slope of it, so the rate of change, with the fasciculation count on muscle ultrasound, and then also with a slight decrease in the median nerve cross-sectional area, and use the ratio for it. And so in their group of ALS patients, they looked at 40 people, as you can see here. They found that this model with a score of 3 or more was very strongly associated with fast progression. And if you look at what patients with ALS like to know from their clinician, this is one of their top questions. doctor, how fast am I going to deteriorate? So combining these clinical with neurophysiology tools might actually be the way to go for these people. Now, if we look at the state of the art for ultrasound in the use in ALS specifically, then I think just screening ultrasound for fasciculations, looking at the echogenicity of the muscles, and adding your EMG will be the best diagnostic capacity for your patient. But you could also do more, right? So you could also look at a split hand index if you scan and determine the echogenicity of the thenar and hypothenar muscles, which are not that difficult to scan. Or you can combine it again with other measures to predict progression. What we haven't talked about much is nerve ultrasound, but because motor axons actually make up quite a small part of every adult nerve, it's kind of hard to use that for individual prediction. So at group level, you need about 160 people to see the motor nerves really decreasing in size in ALS. And it's just a tool maybe for trials, but not for individuals. Excuse me. Obviously, nerve ultrasound may be helpful, and if you have no other means of distinguishing motor neuron disease from things like multifocal motor neuropathy, so the inflammatory disorders that Dr. Borchert just talked about. Now, moving away from ALS, I have a very small dessert, which is just a fun thing that we're playing around with. It's the use of muscle ultrasound for tremor, completely different disorder, but actually pretty handy at sometimes. So here you see a video of a patient with a dystonic tremor. This is the flexocarpi radialis. This is pronator teres. You can see the position of the probe here. It's actually quite a challenge to hold it still. And if I turn it on, you can see the tremor. So what you might notice here as well is that if you look at this video, the pronator teres part of this muscle group is much more active than the flexocarpi radialis. And I think that's one of the areas where tremor ultrasound can be a really quick screen, for example, of where to put botulinum toxin if you want to treat your patient. This is another trick that we have. Every ultrasound machine is equipped with something called M mode. That's motion mode if you want. It's a single image line outlined here. And then you see this moving over time. And now you can really see the tremor frequency in this image. So now we're taking the probe off, and I'll go to the next video. But using the combination of this B mode ultrasound, brightness mode, so the 2D image that you see here, with M mode, can give you a quick overview of which muscle is most active and is a candidate for chemodenervation. And can I get a quick look at the tremor frequency? And that can be a nifty trick if you want. You know, it doesn't take you long. You don't need to put all the EMG stickers on the skin, etc. So this is another example of essential tremor, where you can also see the frequency here. And you know that this is 1 second. So it's like EEG. You're just counting waves within the time window of that 1 second. Here we're trying a different position. You see the tremor change in amplitude. So you can also look at changes with limb loading, etc. if you want. Now, if you really want to go all out and you're a research department very interested in tremor, you might even combine this ultrasound spectrum with a MATLAB, so that's a statistical tool assessment of the frequency. You see the frequency spectrum here that comes from the ultrasound, and then combine that with this polymyography surface EMG recording, where you see, well, it also confirms it's the exact same frequency, but we were expecting that basically. This doesn't have a very large or wide clinical following yet, but it's not that difficult to set up in its basic form. And I think the main point for you to take to work that I would like to leave you with is that ultrasound can be an excellent tool to screen for abnormalities in muscles, but also for things that move in the muscle, like fasciculations, like fibrillations even, also like tremor. It's a good support tool to augment your electrodiagnosis, EMG, in ALS, and it helps to create a more certain diagnosis. And I think it's just an incredible tool to look at dynamic muscle movements. That's all for me today. If you want to know more, we are building more of an international presence as neuromuscular ultrasound enthusiasts. One of the places you might go to see and learn more, and it's free, is Neuromuscular.nl. There's teaching videos there for those of you who are interested. Thank you very much for now. Thank you, Canon, for providing this opportunity, and I'll give the floor back to Dr. Fargeot.
Thank you very much, Nens and Alexandra, for these incredible presentations. Yeah, it was really interesting, really exciting to see how much ultrasound helps us in the diagnosis of many peripheral neuropathies. So there are a few questions from the audience, but maybe I can begin with one or two personal questions for both of you. Alexandra, I am a bit confused with all the different ultrasound scores that have been published, and I have changed many times. Do I have to use one or the others? What do you think in the daily practice? Can we use it? Are they relevant?
Yes, I think you are not alone with this experience, and there are publications about ultrasound scores to try to differentiate the different neuropathies, but also to economize ultrasound workup and examination. But the scores are a kind of orientation, because the scores are all based on a limited set of diagnosis like CIDP or hereditary neuropathies, but not including a complete overview of the differential diagnosis of enlarged nerves. So they can only be an orientation, and you have to know what you are looking for. And they showed us some enlargement of nerves in different neuropathies. So if we know we have to scan the whole nerve, that's why I also said, don't put the probe just on one level, scan the whole nerve and find the enlarged segments, and do this in median nerve, in ulnar nerve, in proximal segments. And then you have to adapt your protocol to the case and to your findings. And I think we need more information and more workup of this ultrasound scores than we have at the moment.
Okay, and maybe the question is a little bit related, and it's a part of a question of one person in the audience. When we speak about enlarged nerves, of course, when the nerve is really big, with the alteration of the echogenicity, it's kind of specific of maybe CIDP. But can you tell us about what other diseases can cause enlarged nerves? Maybe what can we see in diabetic neuropathy or axonal neuropathy? Can we see enlarged nerves maybe in that kind of disorders?
Yes, I like the question, because this is one point we have to take into account. We can have false positive results in nerve ultrasound because we see this nerve is enlarged. We can try to find out as good as possible what parts of the nerve are enlarged. Are the fascicles enlarged? Are the calibers changing? And are other nerves affected? And then we can have a setup of this case, and this in combination to electrodiagnostic testing. Yeah. Because only enlargement is not specific, and we cannot answer the question why this nerve is enlarged if we do not have more information. And yes, we have enlargement in demyelinating inflammatory neuropathies, but we have also enlargement in cervical roots, for example, in degenerative changes and cervical radiculopathy. And we have nerve tumors if it's only one level, like in the ulnar nerve I showed. And so we have to take into account that nerve ultrasound is not able to give us the reason. We need a context, and we need other results to decide.
Always the overall picture and the help of electromyography. Okay, thank you. maybe one question for Nens about fasciculation. One person in the audience asks us about abdominal fasciculation. Is it maybe the most specific localization for ALS? Because we know that some other disorders can cause fasciculations, but it's true that when you find that in the rectus abdominis in EMG, well, it's not a good news generally. What do you think about neuroultrasound? Is it the same impression?
Yes, I think it's very rare to find fasciculations in the abdominal muscles. So we do scan them routinely, and if they are there, I think it's very suspected of a severe, like, multi-level disorder such as ALS. I'm not sure if you have like diabetic radiculopathy at the thoracic level, so like chronic entrapment, or at that level you might maybe find them as well, but that's a very, very uncommon disorder or presentation. So I think in the abdominal muscles, that would certainly make me suspicious. But usually we scan the 4 regions, and the abdominal region is one of them. So this would add to the score. There's been a couple of studies that looked at the distribution pattern of fasciculations in healthy people. And basically everything below the knee, so the calf muscles, the tibialis anterior, that's just normal. But even in the muscles of the floor of the mouth, you will find fasciculations in, I don't know, 1 in 500 people who are healthy. It's rare, but it can occur. So it's the same as with the nerve ultrasound that Dr. Borchert just talked about. It's always the context. You know, you need to have the corresponding clinical context and then interpret the ultrasound results. Getting back to, because there was one more part to your previous question about diabetic and axonal neuropathies. Yeah. So I think your everyday garden variety axonal polyneuropathy probably will not show ultrasound abnormalities. But if you have an inflammatory axonal neuropathy like vasculitis or sarcoidosis, then you will see inflammatory lesions. And diabetes is a debated topic, because they can have slightly enlarged nerves at compression sites, like the tarsal tunnel for the tibial nerve. But some people argue that it's just that diabetic nerves are more prone to being compressed or suffering from it, and they actually do release of those tarsal tunnel nerves. So I'm not sure if there's an intrinsic mechanism in diabetes that makes nerves larger. It's probably a secondary phenomenon. So they're more susceptible to other mechanical influences, for example.
Okay, really interesting. One question, many questions of the audience about neuralgic amyotrophy or Parkinson tunnel syndrome. For example, Alexandra or Nens, at what part of the nerve the torsion is the most common? We know, by the clinic examination that patients can have anterior interosseous nerve palsy and striction at that level, but can we expect torsion in every nerve and maybe in the proximal part, such as suprascapular nerve or any other nerve in the brachial plexus?
Yes, we have to detect the clinically affected nerves, and as good as possible with ultrasound, because ultrasound has its limits in the deeper parts of the nerve. There we have to add MR neurography, but we find that these torsion or these changes in general are very often at the distal upper arm, but also in proximal parts like the brachial plexus. And it's also depending on the clinic of the patient, which nerve you have to follow and how far you can follow this nerve with your ultrasound. That's also a question you have to take into account. Nens, can you add? It's also one of your favorite topics.
Yes, other hobby that got out of hand. I think we know from larger case series that you will find abnormalities with ultrasound in about 75% of the the nerves when patients present, or 75% of the patients will have a nerve that is affected. And it's like Alex says, distal upper arm. So if you were to scan this part just above your elbow, that would be the sweet spot for finding pathology, specifically in the AIN fascicles of the median nerve, or in the radial nerve, and then the pin fascicles. I think that's where the money is, so to speak. If you really are well versed in ultrasound of proximal segments, you could look at the long thoracic in the middle scalene muscle. And usually I'm not sure if I see torsion a lot, but there's swelling. So the basic problem is a nerve swelling indicative of inflammation. You might also see that in the phrenic and in the suprascapular coming off the brachial plexus. Yeah. I think following long thoracic for more than a couple centimeters until it enters the chest wall, that will be difficult because it's beneath the scapula and the humerus or the glenohumeral joint. So those are the sweet spots. But it can be very helpful because you actually find abnormalities within hours from onset. Sometimes we use it if people present really early and the clinical picture is suspect but not certain, or when they're children, for example, and they don't want to undergo EMG. It might be a nice tool to supplement your clinical exam.
And I think there is a debate about what do you do with distortion? Do we have to operate early? Do we have to wait? Maybe among the patients that recover spontaneously, that there are some patients that had torsion and the torsion got away spontaneously. So I think we have to scan every people early because it's a rare disorder, and maybe we know that. Maybe do you know that?
Yeah, you're right. Yeah. Because I start and you take over.
Oh, well, maybe I wanted to refer to the publications of an American group led by Dr. Daryl Snake. He's a radiologist and he makes really beautiful nerve MRI. And so he sees torsions, constriction in a lot of these nerves in acute phase neuralgic amyotrophy patients. But when he follows them up, about 80% of those lesions will disappear spontaneously. And that is very well aligned with our clinical experience, because we have a center that sees a lot of neuralgic amyotrophy patients, that most nerves in most people recover pretty well. But if you have a patient with a severe like paralysis or MRC grade 1 to 2 paresis that doesn't recover within like 6 months, those are the people that we would scan again and look for persisting torsion or constriction and operate if they do not recover spontaneously. But in most of those patients, you do not need to do anything early because most of them will start recovering, unless you have different experience. But this is what I get from our group and the Americans so far.
And even later, they are recovering. So that's definitely right, that we have to debate when and who. From the surgical point of view, they would prefer the 3 months time frame because of the long run, but we as a neurologist and used to wait and see, we have to discuss this, and we have to this is, as you said, it's an international debate, and as far as we know, there is a group of patients who do not recover, and you cannot operate in a very late stage, and so we have to find a solution here. Yeah, we are working on it.
I would say we aim, usually if we want to do anything surgically, we aim for 6 to 9 months, because you give them 6 months time to show that they recover or not, and then you want to do something fast for a good result.
And there are still some patients improving after 9 months, so this is the dilemma we have. Yeah,
absolutely. Yeah.
Okay, let's change a little bit of subject. One person asked us if we can see intraneural inflammation at the nerve root. So I'm not sure if the person talks about inflammation like in CIDP in the brachial plexus or the nerve root, or maybe it is.
We can only see enlargement, and in the cervical roots, he's talking about the nerve root, right?
Yeah.
For example, the cervical roots, there we have not too much resolution, and we do not see fascicular structure. We just see enlargement, enlarged or not. This is what we can see there.
And it's maybe a personal question, but I have some difficulties to measure the nerve roots at the entrance or the exit of the foraminal. And is it maybe better to measure it at the interscalenic region? Is it more reliable than really here at the entrance? Sometimes it's maybe difficult. What do you think, both of you, Nens and Alexandra?
I scan at several levels because, yeah.
I think if you feel comfortable with, delineating the nerve from its surroundings, and you can get the right angle to see the root just before it enters or leaves after the foramen, then why not measure? But if a patient has a difficult neck, some people are like this, it's hard to get in there, then I would just take the first segment where I think I have a valid view, and sometimes I take 2 or 3 measurements to see if they are the same, if there's variability in it, to sort of falsify or verify my own findings.
Okay, and one really interesting question. Why so few alterations in Guillain-Barré syndrome?
Oh, are there?
What is the question again?
Do we scan enough Guillain-Barré syndrome compared to more chronic patients like CIDP? Do you have experience in acute patients? Maybe we can see enlarged roots, maybe?
Yes, you can see enlargement in proximal segments, including the vagus, so the 10th cranial nerve, which is said to be associated with a higher chance of autonomic disturbance, like bradycardia, etc. If you scan them early, like within the first couple of days. But again, I don't think Guillain-Barré is pretty rare. And oftentimes when it's classic, it's pretty classic. So you know what it is, you do a lumbar puncture and then you start IVIG if they can't walk. And there are relatively fewer cases where there's diagnostic uncertainty up to the point that we add the ultrasound, but we do sometimes. If it's difficult, if people have an unclear presentation, or it's a slightly more protracted course, or patients are very young, like children, aged 2 to 3 years, we would then add ultrasound and look for the same multifocal enlargements, and you will find them, I think. But it's not something that you should do this in a multi-center trial, I think. Forgive me.
Okay. I have one question about fasciculations. I'm not sure you told it during your presentation, Nens. How do you grade fasciculation? I mean, in your report, like?
Oh, we don't. We just say they are there or they're not.
Or not, okay. Not like in EMG.
No, we don't, but I'm not even sure if that is, I can understand that you could do it. Obviously, if you see them all the time everywhere, you could say this is a 3+ or a 4+. And if you see them sporadically in a single region of a muscle, it's maybe 1+. You could do that, but I don't think even for EMG, this has been validated in any particular way. So it's a very, very subjective scoring system. We just haven't tried it because basically the thing you want to know is, are they there or not? It's an all or none phenomenon to count in those region scans. And
do you really wait 30 seconds or 60 seconds?
Yes, we really wait 30 seconds.
Yes.
Yeah, but I also do that with EMG, by the way, if people are suspected of ALS. So maybe we 1 minute is quite long, but 30 seconds to wait for a single fascic, I think in a patient who's really suspected of ALS, we think it's worthwhile. So we do it.
It's doable.
Yeah.
Okay. Let's talk about maybe technical question. Which is the frequency of the probes do we use? Yeah, that's really important to know that.
For enlargement or for the detection of enlarged nerves, you can use nearly every system which is available, and you need about 12 megahertz to see the enlarged nerve. But if you want to detect the inner structure of the nerve, you need 15 megahertz or better 18 or more megahertz to see the fascicle and the fascicle bundles. And as higher the frequency, as better the resolution. And you have to take into account that, for example, the nerves of the leg in a deep center of the leg, there you can have problems with your resolution. And so there you can also have limits with not high-grade ultrasound system with a resolution in deep legs.
I'd say that the basic setup of an ultrasound system should probably have a like 10 to 15 or 18 megahertz linear probe for nerves. And you want maybe one convex with around 5 megahertz to scan the sciatic all the way up to the foramen, or scan very obese people. So I think that's a nice base setup. If you leave out the convex and the low frequency, I think you're limited in many adults. So with the sciatic scanning, it will be very hard to do. And obviously, if you have a lot of money and you buy one of those really high-end 70 megahertz systems, you can have great images of the median nerve at the wrist, but then the image depth maximum is about 2 centimeters. So.
Okay, so it's really narrowed area.
Yeah.
Nens, you talked about typical aspects of muscles in case of denervation. And do you consider that ultrasound is really reliable to differentiate, when you have a hyperechoic muscle, between a neuropathic process and a myopathic process? Is it really easy in the daily practice, or is it more difficult?
That is a good question, and I almost feel pressed to. We have lots of ultrasound images from both neuropathies and myopathies to try and answer that question more formally, using, for example, deep learning and texture analysis. I think just looking, so visual analysis, eyeballing the muscle, a really dystrophic muscle like just Duchenne or facioscapulohumeral dystrophy, those muscles have a really typical ground glass aspect, like someone colored them with a pencil and then rubbed them out with an eraser. Very uniform gray distribution of speckles, also like in a liver or a thyroid gland. So if you have one of those classic neuromuscular diseases, I think you will see that this is very typical pattern for dystrophy. But the less classical myopathies may look the same, like IBM is a difficult one. Mm-hmm. That can have very patchy abnormalities which resemble denervation, reinnervation, which they might also have because many of these patients have a neuropathy as well. So I would, except for these really clear-cut cases, I wouldn't rely on it to be specific. Mm-hmm. Again, context is everything. Yeah. But it's a good question, and I feel challenged to do better in this respect and find out.
Okay, so it's 8 p.m. Is there maybe one last question?
Yes, and if people are pressed for time, they can. This is recorded, so you can hear the last question.
Not sure to understand the question. Nicola Carraro, the fact is that the picture you achieve with high frequency for more superficial nerve is quite different than those with lower frequency for deeper nerves.
That is correct.
Okay. Yeah, it's our experience. And
maybe following up from that, if you have a low frequency probe, like in extreme cases, the convex one for the sciatic, obviously your cross-sectional area measurement will become less reliable or more variable. So be aware of using normal values with those low frequency settings because you might have more variability.
Okay, we have an interesting question. how would long-term neuropathic pain appear in ultrasound? Would it change the nerve appearance? Just the neuropathic pain, not the disease below it. Maybe.
So, Alex, you can comment on this as well, I think, but if it all depends on the cause of the pain, really. So we've looked into a little bit for a very specialty area, but pudendal neuralgia, which is a clinical diagnosis, I think, and there are criteria from Nantes in France that describe this clinical syndrome. And if you look at the findings in, for example, electrodiagnostic studies here, about half these people have axonal loss and the other half does not. And in the other half, no one knows what the cause of the pain is. And I don't think you would expect to see anything with that in the ultrasound. Of course, if there's been an inflammation or a tumor, etc., you might, but then you don't see pain, you see that underlying cause.
Perhaps she or he has in mind compression. If we find compression, that's depending again on the context. What are we talking about? Is it post-operative pain, for example? Is there scar tissue, for example? We can see things like this. And we can also see entrapment sites, also atypical levels. But yeah, if the she or he had this in mind, yes, we can try to find out, but it's also depending on the context. Yeah.
I personally scanned several people that had, small fiber neuropathy and in idiopathic small fiber neuropathy, and I can tell you that nerve ultrasound is normal. And yes. I never found, like big and large nerves or.
No, but if you have pain because you have amyloidosis, for example, you will find large nerves, right?
Yeah.
So, yeah.
Well, yeah, that question was quite difficult, I think, but what are the possible causes of nerve narrowing except fibrosis? Usually at the point of stenosis, we see proximal nerve thickening, okay. And what are the causes of the hourglass shape? When the nerve is thickened proximal and distal to the part of the stenosis.
I think there are two disorders where this is an issue. So one is the neuralgic amyotrophy nerves that we talked about, and the other one is probably traction trauma. And what they both do is that they change the connective tissues elements of the nerve. So neuralgic amyotrophy is an inflammatory disorder that affects the perineural sheaths. And we know that if you look at the gross anatomy of a nerve connective tissue supporting elements, they have these nerves have these oblique connective tissue bands running over their lengthwise. And if they become enlarged, this is like the intestines and volvulus, right? So you have a longitudinal structure in your body. There is an inflamed and large segment. And when there is a rotation movement, it sort of kinks over itself and gets stuck. And that is what we think happens with the neuralgic amyotrophy nerves. And then the element causing the kink is that oblique connective tissue band running across the perineural tissue. So that is usually it's just a support tissue for the nerve elements, but if it becomes inflamed, it becomes enlarged and it can become a point of kinking. And I think, but this is something that Dr. Borchert can collaborate or maybe dispute, is that in severe traction trauma, you can have such a disruption of the internal connective tissue elements that you actually almost pull the nerve apart. And then you get two neuromas with a Sunderland grade 4 internal architecture disruption and a very thin element in between. Is that something you also find?
Yes, and also this undulating course of the nerve when the traction was quite strong. Yeah, it's not always only proximal of the constriction, the swelling. That's the core of the question, I guess. And yeah, that's right. Usually the proximal swelling is known, but there are other cases where we can see swelling of the nerve because of other reasons of the cause of the disease. Yeah.
Okay, I think it was our last question. Thank you very much, Nens, Alexandra. It was a great pleasure, really interesting. And thanks to the audience and to Canon, of course. I hope we will see soon again.
Yes.
Thank you.
Thank you very much. Have a great evening.
Bye-bye.
Bye-bye.
Bye.